Johan, Dr. Himanshu will be our academic chairperson today. I will just introduce Dr. Ramneek Mahajan, though he doesn't need any introduction because most of us have taken his services. He has operated upon most patients of everyone, almost everyone here. So he is a senior director in the Department of Orthopedics and Joint Replacement in Max Smart Hospital, Saket. And he has done over 16,000 joint replacement surgery. For that and other, including other orthopedic surgery, it's over 33,000. It's a big achievement. So I will not go into his academic qualification. He has done MCS orthopedic, then he has done fellowship in joint replacement surgery from Singapore General Hospital, and we all know he has over 25 years experience. I have requested Dr. Ramneek Mahajan to start with interesting cases in orthopedics. Dr. Himanshu will take over later, or you can introduce some if you want.
Yeah, so friends, it's a very interesting topic today. Dr. Mahajan will talk to us on the whole plethora of joint replacements. So I just got a brief from him that he will be talking on he will be touching on some of the cases of hip replacement, difficult primaries, difficult revisions, unicondylar knees, total knees. So I leave it to Dr. Mahajan, please.
So good evening, friends. Thank you so much for again bearing with me for some time. First of all, Happy New Year. So, I think when Dr. Chauhan said, take CME, I said, probably sir, we've done everything that we can cover, and instead of repetition, let's look at some things which can come to you. Maybe a patient comes to you for a second opinion after he has met me or someone. Or somebody who has already he's come to you for the first time and you know he needs something. So you can only be a friend, philosopher or a guide for that patient if you actually understand what we do. So when we understand what we do, I thought let's look at interesting cases. And I will not go into much future, past, Purana. This was only in December. A few interesting cases that we did in December. And we thought this probably will be a good idea that these are the kind of cases that can just come into the OPD. A patient, routine patient, 58, bilateral, and the first question comes into the mind is 58, koi baat nahi aur thoda chala lo. But then comes, are you grade 1, 2, 3, 4? Is a quality of life is the most important thing. Then comes pain. And if you have all these x-rays, you know they are worn out knees. They are not working for that patient. He is not being able to go to his office, he is taking painkillers. If he doesn't walk, he gets other issues. So you all know he is only making it worse for himself. And when he takes a long film, you realize that this is not the right person. And you, what does he have? Only diabetes. You tell him as a physician, control karne ke liye walk, and that's the first thing which he can't do. So, very routine, simple knees. Better idea is to give them a good balanced knee. Go ahead, fix them up, straighten them out, and they are at least comfortable into the society. So that is what is a primary, simple, bilateral total knee replacement. Whether we do one knee, whether we do both knees, that is depending on the patient sitting in front of you. If he is 80 years and above, he is not getting a bilateral. Even if he needs a bilateral, it will be one at a time. Reasons, a body cannot take the stress of two knees together. After 80 is just a number. But then we all talk of evidence-based medicine. So the American Academy guidelines are very clear. If you are above 80, it is better to stick to one. If you are a cardiac patient, you have had some CABGs, some PTCAs, it is better to stick to one. And you can always come back after 6 weeks and do the other one if you need both knees. If you don't need both knees, you don't need both knees. You need only one knee because you are looking for balance. So that is what comes down to. 58 can straight away go ahead. Now look at this one. This is 68-year-old female. And as you grow older, although as Dr. Chauhan was just saying 46, had a problem. Problem can come at any age, but mostly when you start aging, you start adding medical comorbidities. So we started off with a case with a simple diabetes. Here is a patient with diabetes, hypertension, atrial fibrillations, obesity, and a BMI of 32. So everything is getting added. And when you start looking at this, a 68-year-old with all these problems, obesity, whether you do 1 or 2, if you are a BMI, your cutoff is 35. BMI over 35, it is better to do 1 at a time. 32, you can still manage. And what do? You give them both knees. So you're okay to give them both knees, but see what we have done. If I go back, if you remember the previous X-ray and this X-ray, we have added this to the implant. We have added this to the implant. So this is just an additional step that has been added. So this is where we use in either osteoporotic patients or obese patients, so that you give them more inherent stability. It is all packed out with cement. That's a short stubby step. But it adds more stability and to the implant, so that it prevents the rocking movements that the weight of the patient can give, or osteoporotic knees can collapse. Like butter, you can just collapse. So you add more stability, and that is what you can do. So then, if you look at a 69 again, hypertensive, but see how the story begins. This lady probably had it for the last 10, 12, 15 years. Did not choose a surgery. Kept lingering on. So when she was lingering on, you can see something happening here. You can see something happening here, which you can see more on this and this. These are defects. Because whether it is osteoporotic, rheumatoids, whatever, when they start to load eccentrically, they end up causing defects. So these defects means now as a surgeon, you will struggle not only to give them a balanced straight leg, but to put an implant you need a platform. हमारे घर में भी अगर किसी को टाइल लगानी है फ्लोर पे, वो टाइल तभी लगाएगा जब surface has to be flat. So then that means me as a surgeon has to look for a flat surface to put the implant. That means there will be some additional component or something to be done here to get a flat surface which can get an implant. So this is unbalanced, we can clearly see. And this patient does not have it. I will subsequently go to another X-ray where if this patient does not take the surgery now, ends up with some cracks here which are called stress fractures. Because you can't keep bending something. Everything has a break point. So they all, and then osteomalacia, osteoporosis, all those things, and then they come with the stress fractures. As a physician, the first thing that you see in your clinic is your follow-up patient who used to come to you walking, whether with stick or with walker, now comes to your clinic on a wheelchair, is not able to stand. Don't put your hand on the knee, go down the knee, on the shin, and simple percussion. You know bed percussion more than me. And start percussing that on the shin. If they tell you they have pain below the tibial tuberosity or on the shin, they are developing stress fractures. That is what is happening. They do not treat at the right time and they start cracking and breaking. I'll show you how. So in this particular case, if you see, this lady came on a wheelchair. So somebody who has not accepted a surgery for so many years suddenly lands up into the OPD and says, "Meko surgery karani hai." Means what has triggered this? Either there is a crack, a fracture, something has triggered, or a fall. So this lady, just for the sake of demonstration, our physiotherapists like to get the patients out of bed just to see. So when she was standing, not even able to walk, this is what we had to do. along with some stems. This extra pieces are the augments. So these are the augments which are placed on the bone attached to the implant. So when they sit, they create that depression and cover the depression. So that is what is an augment. So this lady gets an augment. And look at the lady, if you see on the left, this is on the same day 2 hours after surgery, the physiotherapist is trying to make her stand. The thing is, somebody who is not able to even stand, tries to stand after surgery, that these are the happy signals which can go to the brain. This is where the fear factor starts to go out. There is nothing to keep them in bed. Once they are fixed properly, they just need to stand. And look at the same lady, next day morning, does not need anyone to help her. She probably tries to put her legs farther. So we are not pushing them out, we are just making them stand. So somebody who has not walked for a few years, if she is able to stand after 2 hours, those sends those happy signals to the brain that something is actually possible. Next day morning they actually start helping you. These are all December cases, so I will not give you a longer follow-ups. Dr. John mentioned those Purane Wale, that is why I did not bring them. Now look at this one. Came all the way from Kenya. And what happens? Look at this. I will show you this hypertensive, all those things go in. But look at the knees. They were such bad knees that the continuous wear and tear actually led to no condyle. If you see, there is no condyle on the medial side. Even the intercondylar eminence is gone and the lateral side is gone. So this lady, actually that's where the defect is. That is the tibia that I have. I don't have anything more than that. That is one. So now, augments are out of question. Now you have to actually build bone to put an implant. The augments cannot help you here. A simple augments will not help. You need something more. And then, if you look at them, that is how they stand. Walking is out of question, but the willpower to stand is what. And if you tell them to walk, see how she supports with the right forearm. Just for helping that video, that how if we make you walk, how can you walk? This is how she would. She would support herself with the forearm just to stand. And this is what we did. So this is a mesh placed all around the tibia upper end. Bone is packed into it. And it's like, जैसे हमारे घर में the plumbers, the तरखान and all those things, गड्ढा भरने के लिए वो छोटे-छोटे बजरी डालते हैं, उसको डंडे से कूटते हैं. वो उससे वो surface बनता है. So this is actually impaction bone grafting. We take a lot of bone, allografts, and then you pack them, hammer them, crush them, so that they become solid base, which can then take an implant. And look at the same lady, she is still in India, it's only 3 weeks after her surgery, and this is the video which she has just sent me in the evening today. यहाँ आना था तो मंगवा लिया, physiotherapist से, that she is now trying to walk without support in 3 weeks. That is what, because she could very well balance her out. This is what you can actually achieve with these patients, but we as doctors want them on time. The more you come delayed, we have solutions, but it adds more to the misery. Look at this patient again. This is 61-year-old lady. If you see the date, I have added this because I have done this surgery today morning. Oh, wow. She came yesterday from Jharkhand in the OPD with this much investigations कि डॉक्टर ने वहाँ पे सारे करवा दिए, कहते दिल्ली जाने से पहले ही ले जाना, and now admitted. So they came and they got admitted yesterday. Today morning her surgery happened. You cannot make out something here. You cannot make out anything here. But if you see this line now, there was a very faint line which could be a crack. That is why this lady now just says कि आज तो surgery करानी है, लेकिन मैं खड़ी भी नहीं हो पाई. Forget about putting a step forward. This is when we made her stand photo के लिए. But if I made her कि आंटी खड़े होकर दिखाओ, this was yesterday evening. You see her right leg. She was not just dragging, but could not put it on the ground. She just could not put her weight. That triggers, if there is something more happening. That is why this lady who has not chosen a surgery for last 10 years, now suddenly says, "Aapko karna hai kuch." That is what this was. And this is my intraoperative picture. The moment I put a stem in, I realized this fracture is actually opening up. You see this faint line on the C-arm image, जो X-ray में नहीं दिख रही थी, but C-arm में दिख रही थी कि भाई यहाँ पे कुछ है. See that line? It was there. So if your mind is not open to this, and you put a simple implant, these patients in the post-operative period will come back कि चलते चलते ठोकर लगी, गिर गया, fracture हो गया. The bone doesn't break like this. It was something which was probably missed. So this patient, instead of a smaller rod, got a longer rod. And look at this. This is 4 hours after the surgery. Today in the evening she was made to stand and she was able to stand on her leg. Forget about walking, that will come couple of days. But we made her stand today. So this is what is the difference that you could achieve, that absolutely straight legs from whatever with some augmentation and all those things. Now this was a 52-year-old. Now why should I operate on myself? I am 52. But if I get a pure isolated medial compartment, only one half of the joint is involved, which is stage 4. So this is grade 4 osteoarthritis of the medial compartment. So either I tell this patient कि भैया 3-4 साल का सर्जरी मत कराओ, दर्द सहन करो, या इंजेक्शंस लगा लो, या ग्रोथ फैक्टर कंसंट्रेट लगा लो, but that is not solving this patient's problem. So you have to look for something else. So what is that something else? A partial knee. It acts like your temporary spacer for next 10 years, 15 years, 14 years, 7 years, whatever. But on those 7 years, 10 years, 15 years, you are doing your activities. You don't know when this side of the joint will wear out. So this might last longer. I can tell you, 2003, I landed in Delhi. Dr. Kalia, you also is there. Yes, sir, 2003 I operated on a lady. In Delhi, I was Ortho hospital. 1 knee total, 1 knee partial. That auntie still comes to my OPD, meets me partial abhi tak chal raha. And that was a purana zook. So nobody knows when it will wear out. At that time the auntie's age was 58. I am talking of 20 years back. And that partial is still working for her. So you don't know when. But at least the quality of life is achieved. So partial knee is definitely an option. Now look at it. From knees I move to something else. Long time back, patient has been operated. Everything has a shelf life. Now this implant wears off. This was done 10 years back. Left side has gone off. There is pain and instability. There is always a solution. We investigate, and once you investigate, you find there is loosening, there is no infection. So they just need a revision. So that's a simple revision done. The implant is taken off, a newer implant is put in, and the knee is again ramrod straight. These are called aseptic loosenings without an infection over the years. But then somebody can have an infection. A recent 2 years back gets an infection. So when say patient gets an infection, when you have those parameters, treat them and remove the implant and put in antibiotic spacers. So these are antibiotic spacers inside. These antibiotic spacers are made inside the operation theatre by us, put into the knee, shaped like the implant, keep leaching out antibiotics, and over a period of 6 weeks to 3 months, when you are sure that the infection is eradicated, you can go in and do a total knee again. So that's the total knee done again. That's the X-ray. A revision implant, keep taking into account all the bone loss, and the infected knees can be tackled. So this is another one of those revision knees. Absolutely well straight balanced knee is what you look for. Now, Another thing that can come up is this lady 13 years back gets a total knee, is severely osteoporotic. I can tell you that her osteoporotic status was that I could put my pin into her bone with my hand. Forget about hammering and drilling. It was like a paper. You can see the pencil thin cortices. The cortex is actually eaten up. And so this lady gets a fracture. This will not hold. With 72 years and a CA prostate. Oh sorry, this is a male patient, sorry. Female. This is a male patient, CA prostate, the female eye. And this what you want to realize, you know this needs something else. So you see this, that's a limb salvage, a tumor prosthesis. So you remove the area which was involved and put in this implant, and that again works for the patient. So my options, I have many on the shelf. I can go from one end partial to a complete tumor prosthesis. So much of options are there. It is on what stage the patient is on the table. Like this is a partial knee, and I said gets a partial knee, but it wears off after some time. So partial knee gets worn off after some time. Will the same way as a total gets a new implant which is total. And once it is done, the patient is up and about. Now sir said robotic padayega. मैं बिल्कुल नहीं पढ़ा. But that is what we do nowadays. Most of us is robotics with us. Now with my center and me, we are now close to 1,000 plus. I think we are logging in by this month, and we should be logging in 1,200 plus robotic surgeries, which includes knee, partial and total. And we are the busiest robotic center. And this is what we did. This patient needed an arthritic knee, and this was an implant inside and required a surgery. So either we remove the whole implant because you don't have technology, but that is what robotics helps us. You can conserve bone. And when you can conserve bone, we knew the implants are already pre-decided with us. We are sure that this is the sizes which need to be balanced out in both flexion and extension. And when you look at robotic, how does robotic help? It has given us the size of the implant. It tells us that if you remove these two screws, you're done. You don't need to do anything more. Remove these two screws and you can actually go ahead and do the surgery without touching. It's like a quick in, out, nothing helps. And this patient got a bilateral total. So with those things, these are extra-articular deformities, old fractures, and they can still get a simple implant. But again, this is robotic. These are fractures which have been neglected. Nobody treated a fracture, missed a fracture, gets a plaster, then gets quack to come in, and these fractures around the knee were missed. But when she came for a knee surgery, we realized that this was actually not an arthritic knee, this was a neglected fracture, which has brought her to us. That was the fracture. Gets a CT scan so we can see the line now going there. Gets a robotic panel. With robotics, you knew that all those sizings can happen, or the implant can come in. And you can see intraoperative, we just fixed the fracture with a couple of wires. With that, we knew where we were. We don't need to fix the fracture, we can still manage to do a knee and then put a couple of screws and the MCL got an anchor and we were there. And that's the patient. And look at this patient. She was a stiff knee in extension with a range of movement of only 30 degrees. In 3 months, she got 130 degrees. And this was a video taken yesterday. I called her to come, and this is how she is walking in 6 months. Where she was doing every activity that even I can now think of. That is where, this is stress fracture, which I just mentioned. This is frank, you can't miss this. But that was subtle, which I showed. And you can fix the fractures up. Wheelchair bound patient, fractures, needs an implant. Implant cannot go in. If you see this direction, the implant cannot go in. So either you open the fractures again, break the bone again and put an implant, or you do something which is different. What we did, we used, these are called offset couplers. So you can use offsets and change the orientation of the stem going into the canal so that the fracture is still held in place. The implant is at the top, and the offset shape means that 3 months only the fracture has healed. The patient was able to walk within 3 months. The fracture was not healing because it was an arthritic knee at the top. Had somebody treated the arthritis first, the fracture would not have actually gone beyond that. So you fix the fracture, you don't need to fix the fracture, treat the root cause, and they can actually get out faster. And this is 2 months post-operative consolidation. And that's hip. I don't want to go much into this now, but see, any age, robotic hips, you can go ahead, that's robotic hip. That 68-year-old female with an osteoarthritis, rheumatoid secondary arthritis, gets a hip. That's old fractures. So these are some fractures which probably this patient went, somebody did a valgus osteotomies, did not heal, and at the end, when they landed up with us, we put in a cage. So again, as in hip, as in knees, hips, we have different options. So you can get this. So I think probably everything is possible, including bilateral total hips, same settings. Our paper is about to come, sir. We have the highest, at this moment, series of 68 simultaneous bilateral total hip replacements, and the paper has just gone in for publication. And that's bilateral total hips, same sitting, patient made to walk. Thank you so much.
Thank you, Dr. Ramneek, for showcasing us so many cases of knee replacement mainly and some cases of hip replacement. So I think the same surgery with different indications, and one lesson we can take today that the surgery is required in even 58 or 56 you told. EPD indicator should not delay it, otherwise surgery may be complicated. The only question here is why physicians are not referring younger patients than 60. The question in mind is the implant life is maybe 20 years, 25 years. So what will, suppose surgery is done at the age of 55. So will this patient definitely need another surgery after around 80 age or at the age of 80, or this implant may, you said you cannot say the fixed life of implant is 20 years, 25 years. So but you will expect another surgery after the age of 80 in that case.
Sir, if I go with evidence-based medicine, the longest follow-ups now in the literature are coming at 40-42 years. And there are published data in the journal of bone and joint surgery. And if I talk of somebody telling, and if I say somebody talking of 40 years, he is talking of implant which was probably done in the 80s. So when 80s implant, a well-done surgery is lasting for 30-40 years, why should a well-done surgery with newer implants, newer technology, with more and better understanding of the implant, it should also last a lifetime? But I cannot guarantee what is not published. But if I have to tell someone, the only line that I can tell is, the older generation implants, the literature is now published, which is talking of 40 years, 35, 40, 40. So why should newer implants not work? Yeah. So probably the surgery has to be well done on day one.
So surgery should not be delayed on this presumption that this patient may require another implant. This implant may last for another 30 years, 40 years also, may not require another surgery. Okay, Mansur, please.
So I fully agree with what Dr. Ramneek has said. In fact, the partial knee replacement, probably the earliest one which came, is something which we call as the Oxford knee, the mobile bearing knee, and now the Oxford knee completes a data of almost 42 years. So it's a unicondylar knee with 42 years of mobility. I think what else do we need? This is partial. And I think Dr. Ramneek has covered almost every aspect. But I just, if you allow me, I'll just give a very quick, things which I just thought. A very important point from his talk I wish to emphasize is that I think we need to pick up the patients of osteoarthritis at an early age, because if you pick them up the lesser deformity it is, the lesser the mobility is. Number one. Number two, partial knee replacements vis-a-vis total knee replacements are actually giving phenomenal results. It's a smaller incision. Your patients are actually going up and down the stairs. If you agree with me, probably second or third day, particularly with partial knees. Then Dr. Ramneek emphasized a very strong point that was on osteoporosis, which I think all of us, whether we are physicians or surgeons, we see in our clinic. The simple logic is a bad soil cannot take a bad plant. So it's as good as that. I explain like that only to my patients कि आपकी जो basic खाद है इसमें हम पौधा लगा ही नहीं पाएंगे. You need to actually improve that. You need to have some kind of supplemental fixations like you shown in the form of intramedullary rods. So I think an osteoporotic patient should not be condemned कि इसको improve करें and then we do something for it. Everything can go hand in hand. Particularly with these newer drugs, the so-called recombinant teriparatides, things go simultaneously with knee replacement. And one thing which I would like to ask Dr. Ramneek is, there are times when you have, say, a 65, 70-year-old person with very severe bilateral deformity of, say, a genu vara. So in such a scenario, would you prefer to do a staged procedure or would you prefer to do a single stage procedure?
65, 70.
I would put it at maybe 75. They're very hesitant. They never came to the doctor.
So if they are ASA 2, max ASA 3, I would probably do them on the same setting. But if they are 3 or 4, then it has to be one at a time.
ASA 2 and 3, 4.
Anesthesia. These are anesthesia guidelines. So anesthesia guidelines. So and the thing is, what you are trying to look for, all of these patients go for DACs. So what is their cardiac status and what is their creatinine clearance? We are looking for these two things. I am not looking at anything else. HbA1c is a grey zone between 8 and 9. Some books says 8, American Anatomy says 8, Orthopedic guidelines says 9, and so we're not going on that and we're not debating. But the guidelines which are very clear is, if you cannot make a patient stand next day morning, then it is better to do both together. But the risk factor of using or not using technology. If you don't use technology, you want to drill a hole into the femur, put a rod, and that gives you a thrust of emboli into the blood. So you increase the chance of pulmonary embolism. Then it is better to use a technology which does not open the femoral canal. The cardiac status, yes, if they are above 80, don't have a choice. But all those bad X-rays that I showed you, all of them were operated on the same thing, 65, 70s, because even if I do one, I will not be able to make them stand because the other knee is not at all supportive. If you don't have a support, you can't stand.
Dr. Ashok Chakraborty, sir.
Good evening, Dr. Ramneek. Wonderful presentation and really impressed by the cases you really operated for, and they're almost walking about 4-5 hours after the surgery. I got one application to closely much of cases of osteoarthritis and things like that. But still, relations and close family people keep on asking Ashok, Ramana chahiye ki nahi karwana, because they are offered the surgery, offered. My one question is, Dr. Ramneek, what's the absolute contraindication? You have told the contraindication. Contraindication क्या है? Sir, knee surgery. थी क्या थी?
If you are not fit to undergo the surgery, the anesthetist does not clear you or the cardiologist does not clear you. Because that is the only contraindication, number one. But relative contraindication if you have an infection in the same limb.
Okay.
So that means suppose we have not operated knee patients who have either a hip infection or a toe ulcers fungating with varicose venous ulcers, first then we don't operate because if there cannot be a source of infection in your body. That is why all patients are told about dental hygiene and private part hygiene.
Okay.
90% of the infections they come from private parts. UTIs.
Okay.
Elderly aunties with flabby stomachs, and under the stomach if you lift it up, pura fungal infection. Then prolapse of uterus, UTIs. So all of these patients have to actually go for this checkup before we do their surgery.
So you have got a team for PAC.
Oh yes. So So that is where again I differ from 90% of the surgeons,
Right.
and I have lost patients who have not gotten their surgeries operated by me. The reason being, I am very strict on they have to do their investigations before they admit. And most of the patients who want कि admit करके सब करा लो, because वो invest उसमें निकल जाएगा, insurance में और किसी में. But I am a stickler for rule that they have to first investigate, and if they are cleared, only then I will admit, because it wastes my time and resource, because I am next day OT में whatsoever, और कुछ भी निकलेगा मैं घर भेज दूँगा, ऑपरेट करूँगा ही.
Very good. Thank you so much. Thank you. Dr. Manish Gupta has a question.
Sir, adding to the list of this contraindication, would a neurological deficit like PIVD or lumbar canal stenosis be a contraindication or something of that sort? Point number one. Point number two, most of the patients as family physicians present with pain, and bilateral would think probably osteoarthritis. Unilateral you might think probably neurological. That's what we take. So a comprehensive neurological exam before the subject, yes, X-rays with age would show grade 1, grade 2, grade 3. The American thought is, yes, we don't want to live a day with pain. And with the new risks and all that, yes, that's part. The X-rays you showed were grade 4 and beyond. They definitely need surgery, no question about it. But my only question as a family physician to an orthopod is, sir, sometimes we have a case of a double hitter. Right? Most of the cases, because of their improper posture and the waggling gait, they have also caused over long term PIVDs, lumbar canals, and worsening. Even if you do the X-ray of the spine, they're worse. So sometimes the pain still doesn't go away post surgery. My critique.
So point well taken. So what we normally look at, all of these patients undergo investigations, clinical, and उसमें neurological does come. So if you don't have a quadriceps power, you are less than 4, you cannot lift your knee up, then that means you are not a fit candidate for surgery. Then you have to go to your spine surgeon to get your spine surgery first before you come for the knee surgery. But now the caveat comes. Caveat is there would be patients who have severe lumbar canal stenosis and severe osteoarthritis of these kinds. What do? Even after their lumbar surgery, they cannot stand because they need that. If they are good candidates, then we ask the spine to operate, and then we can operate the knee the next day or after 48 hours. There are times when we tell the patient that you are those borderline that you will need a spine surgery, but you can wait for the spine surgery because you don't still have that deficit lower down. You have claudication, you have paresthesias. These are neurological signs, not orthopedic signs. They will remain after surgery, but the pain that will come because of the arthritis in the knee, that can be taken care of. So the example that we like to give is that you have a van which is moving, engine is bad, tire is bad. You don't want to touch the engine, you can change the tire and keep moving. You have a bad engine, a bad tire, you do the engine, the car will still not move. So then you start balancing out what patient to take into the theatre. So then the statement to the patient was, as doctors you all know, अगर एक बार कोई बीमारी हुई है, सर्जरी हुई है, दूसरे हिस्से में भी कोई तकलीफ होगी, तो it will be correlated to your surgery. So इसलिए you have to tell them right that your neurological signs will still remain because they are from the spine. Diabetes, that is one of the most important things that we have a problem. Peripheral neuropathies, patient feel मेरे को जो peripheral neuropathies है वो नींद की सर्जरी के बाद क्यों नहीं, वो क्यों नहीं ठीक हुई, varicose veins, वो क्यों नहीं ठीक हुआ, vascular claudications, वो क्यों, and patients don't stop smoking. So those are other problems that we face. A detailed history, that is why is taken for all patients.
Dr. M.P.S. Gandhi sir has a question.
So I'm thankful to Dr. Ramneek Mahajan. In fact, I was operated by him on 1st April. I'm perfectly alright. You have put me on teriparatide. For how long do you give it? And is there any important side effect which has to be looked into for teriparatide?
Sir, Normally, teriparatide as a course is for 2 years. But what we look for are two things. One is hypercalcemia. That means you have to continuously monitor your calcium levels. And two is parathyroid hormone. So if your parathyroid hormone is increasing or your calcium levels go up, then we stop the teriparatide.
Dr. Brajendra Singh, I have a question.
Sir, very nice presentation. I have three small queries because you are an orthopedic surgeon as well as a physician. Osteoporosis works to your advantage or disadvantage. Number two, the way you are being popular, वो दिन दूर नहीं जब प्लम्बर और कारपेंटर आपका उदाहरण देके काम किया करेंगे. तीसरा, tell us something about degradable nano paste which heals the bones.
मैं समझा नहीं लास्ट वाला क्वेश्चन सर. पहले वो सुनना पड़ेगा.
Nano paste that heals the bones.
Nano paste, are you using nano paste?
I don't have any experience for nano paste.
सर आप इंटरनेट से पढ़ के
हमारे पास जहाँ तक osteoporosis is something which cannot be ignored. So इसलिए all patients we do an osteoporotic. We do not do bone densities for all because if it is a fragility fracture, it is osteoporosis. If it's a wrist or a spine fracture or a intracapsular fractures, trochanteric fractures, they are presumed to be osteoporotics. And if you're doing a knee or a hip replacement, intraoperative bone की feed से पता चल जाता है कि this is osteoporotic. So they all get this, whether in teriparatide or denosumabs or calcium supplements, they all get it accordingly, depending on their age group and whatever they are.
Dr. Ramneek, my batchmate and my roommate for half the time was a Russian. And Dr.
सर ये आधा बातें करता है. ये आधा बड़ा important है.
I keep telling that, so मैं बता देता हूँ, मैं 245 में इसके साथ था और 264 में उसके साथ. These are the room numbers in the hostel of
Dr. Ramneek, what is aseptic loosening? When does it present and what percentage of TKRs present with aseptic loosening afterwards? And second question is how many revisions have you done? Second, third, fourth?
Sir, aseptic loosening means when there is no septic. That means the knee implant has gotten loose or a hip implant has gotten loose but without infection. Most commonly it happens because of wear and tear. Then there is something called osteoporosis, fractal. If it is a cemented implant, the debonding of the cement. Then metallurgy of the implant. So if you remember, there was in Johnson & Johnson के लिए वो आया था implant and all those things. All that was aseptic also, loosening. So what happened is the metal was a problem. So those metallic reactions, those are aseptic loosenings. So aseptic loosening is a different than that if you ruled out infection, then you can do. And regarding revision, let me tell you
What percentage of cases does it happen? Subsequently,
aseptic loosenings less than 1%.
Less than.
But what is it? What it is? It is all revisions as the number of primaries are going up, the revisions are going up. There was a time जब हमारे पास में रिवीजन का कोई केस आता था तो हम लोग ग्रैब करते थे यार बड़े ये अब एवरी डे इन ओपीडी आई सी वन रिवीजन केस जो 15 साल 20 साल कहीं भी हुआ है पेरिफेरी से वी आर गेटिंग सो मेनी आयुष्मान पेशेंट्स so every periphery every nursing home is trying to do it and they are coming in bulk so every day I see one every week we operate two. So if in a month, if a surgeon, let's say, is doing 5 to 10 revisions, that is a very big number, you would tell me.
5 to 10 in a month.
In a month is what we are trying to, because that is how it is coming up.
Dr.
Have you done third, fourth revision?
I have,
Is that common?
sir, then next time it will be a CME on those cases of revisions. Then I'll show you, I have a patient, RT, got operated 4 times elsewhere, 2 times by me, 6 and then the 7th definitive surgery and she stays in CR and she's actually walking and moving. But so I had to plan out for her. On 17th, so why revisions have come up, so that is why so many things have come up. On 17th January, we have a case lined up. And probably next one of the CM will show you. Even the implant for that revision, it is 3D printed. It is a 3D printed implant. We are operating that lady who is 78 years old. Her fourth surgery, so there is no bone. No implant which is custom made can go in. So these implants are actually being made for her after 3D printing. They are coming to us, it takes nearly 3 weeks to make them. And then those are the implants which we will be putting into her. I think probably this will be the first case in Delhi for these implants bilateral on 17th January.
Dr. Ramneek, we have a question from Dr. S. Nigam sir, former HOD of Pathology at Aravind Hospital.
So, Dr. Ramneek, it was an excellent talk, and I had the opportunity of listening to you for the second time in this forum, and it was a very good talk. So, I just want to know that in one of our relations, at least 2 instances I know, when my relative, aged 48 years, was advised, TKR, which was not indicated. You think that it is being, like civilian sections, not warranted, but still being advised by some of the orthopedic people, and they have done without TKR very well, and in fact, I think, so what is your comment on this?
So you want to attract his attention and you want to comment on the unethical use of TKR in young people. In young people,
Especially.
Sir, anything which is unethical is not acceptable.
Yeah.
So I tell you, if I say whether it is happening or not, I would probably not go on those lines, because I tell you, sir, why? I tell you why. No, sir, I tell you why. To comment on something whether it is happening or not, I probably am not the right person. I should not be saying it. But I can tell you, age should not be the criteria to not operate. Because if you say 48, then you will murder me or crucify me when I tell you that the youngest that I have operated was 14 years old, 1/4. Where I did both hip replacements. Then, uske baad I have a 16-year-old, 17, 18 Sala, and the youngest that I have operated all 4 joints. That means 2 hips and 2 knees was 24-year-old girl. And now that girl is around 33, 34, still doing well. So age cannot be the criteria. Indication and the right indication, if it is a criteria, should be given. A juvenile rheumatoid arthritis, JRA, burnt out hips, burnt out knees, why will we not operate? They are not improving. And as Dr. Poddar was mentioning, 48 or 50 mein chalaye or kitna chalaye or those things. What are we aiming for? Only one. Quality of life followed by pain. If you say, let's say me, I say यार मैं 54 में नहीं कराऊंगा, मैं 70 में कराऊंगा ताकि जिंदगी में एक ही बार कराना पड़े. 54 से 70 की गारंटी क्या है कि मैं रहूंगा या कि नहीं रहूंगा? तो मैं तब तक खड़कता रहूं. Then that does not solve it.
I and
Dr. Nigam,
I must tell you that you have operated one of my very good friend's wife, and he was so happy, and he was all praise for you. You have done it.
the patient who was operated at 48 may not be unethical, because what was the indication?
No.
Only age cannot be.
Dr. Poddar, Dr. Nigam is saying something else. He was advised TKR, he was not operated, and he is doing very well even now.
Okay.
So that brings Dr. Ravi Garg, our second orthopedic person who is actually eligible to ask questions, will ask a question.
सर मैं तो 90 इयर्स के पेशेंट का मेरा किया
माइक डॉक्टर रवि माइक
द्वारा बोलो सर ने 90 इयर्स ओल्ड के ना पेशेंट का ना ऑपरेट किया. चलिए
अच्छा है ना पेशेंट
वेरी गुड.
Sir, certificate of appreciation. Dr. Rajni Chakraborty ma'am, I'm so happy that we came with Dr. Ashok today, and she has a question.
And I just want to know what are the post-operative instructions for the patient? How much, like the patient could not stand, patient could not walk, but can the patient run, can the patient climb? If that was the lifestyle prior to getting the knees damaged?
Ma'am, the first thing that we do, what I do, is that every patient we try to counsel कि घर में जो आपसे डरता है उसको साथ में लेके नहीं आना, जो डरता है उसको नहीं लाना है, so that the caregiver, the thing is a patient is encouraged to do everything with their own hands. That means we try to tell them there will be no catheters. Unless until because of prostate issues, there will be no catheters. So if you have to pee, you have to get up because we will not give you diapers. So we encourage you to stand. If you can't walk to the toilet, you get the commode chair next to your bed, but you have to stand and sit there. So that is the first criteria. When you go home, nobody should give you water, nobody should give you tea. If you want to have water, walk to the kitchen, वहाँ पे पकड़ा देगा. You want to have tea, please stand and make your own tea. That is balance exercise. Nobody will fall. मैम गिरेगा कोई नहीं, पर वो डर है जो गिरा सकता है. So if you try to stand from the second day to make a cup of tea, हर बार तो नहीं बैलेंस करना है ना. पानी डालते समय 1 मिनट के लिए छोड़ दिया, फिर स्लैब को पकड़ लिया या वॉकर पकड़ लिया, चाय बन गई, उसके बाद चाय पोर करनी है, 2 मिनट में क्या 2 सेकंड में पोर कर लो, उसके बाद में पीते हुए निकल जाओ. Then somebody can get it for you till your table. The thing is, the smallest of activities when the patient does with their own hands, they feel more comfortable. So we encourage you to step out. Forget about your stitches. That is my problem. You have to go for a walk. And the targets that are given is by the end of 1 week, you should be walking at least 1,000 steps.
Wow. Yeah.
There has to be a step counter. आपके phone में या you should be wearing a watch. I think doctor can tell you. When I pushed him कि इनको चलना ही चलना है, ये मान भी रहे थे. मैंने कहा सर मेरी बात मान जाओ, चलना ही चलना है. चाहे आपको चाय अपने हाथ से खुद बनानी पड़े, नहीं आती तो सीख लो.
नहीं डॉक्टर साहब को तो खाना बनाना भी आता है.
Climbing stairs.
Ma'am, everything and anything. Climbing stairs, we start from day 2. So people who stay on the 2nd or the 3rd floor cannot stay on the ground floor. They have to climb up. The only thing we try to make it easy for them is climb 8 steps. You have a platform, sit on the platform. Again 7-8 steps, you will be on the 1st floor. First floor वाले से अगर लड़ाई है तो ऊपर तक चढ़े जाओ, नहीं तो उसके घर में पानी पी लो. Again the 7-8 steps, sit on the platform. आप 3rd floor रह जाओ, 2nd floor वाला चाय पिला देगा. And you reach the 3rd floor. कौन सी मैराथन भागनी है कि अभी 5 मिनट में ऊपर पहुंचना है, 15 में पहुंच जाओ. But the more you try to go up and down, you feel more independent, you will be better off and more confident.
And it won't be damaging your...
You nothing. Why will you? The implant is meant for you. What will you damage? The only thing is if you don't learn how to walk, if you don't hold yourself and you stumble, those are the times that you can break my stitches, which are inside.
What about squatting? Thank you so much, doctor. Thank you so much. Squatting, is it
half squat, not full squat, half squat.
Dr. Jitendra Saxena, our proud batchmate in this erudite and sophisticated gathering, I cannot call him sexy.
Sir, my question is, I think either of you can take Dr. Zagate, sir. I think anyone. My question is about something slightly, just recently 10 days back. मुझे नहीं पता था कि पूरा का पूरा upper limb भी replace होता. So there was, I just came to know 10 days back. Cadaver operated at Amruta Hospital. Kerala, yes sir. So they have a team, they do maximum number of upper limb transplant, पूरा का पूरा limb, सब मुझे नहीं पता था, I went to Google and see कि क्या-क्या indications हो सकती हैं, तो सुबह तो याद भी नहीं आ रही, like tumors,
burn injuries, tumors, crushed hands, so it's like doing a heart transplant or lung transplant.
yes, so just wanted to know sir, इतना तो मुझे पता चल गया कि है क्या चीज, कैसे करते हैं, how difficult.
It's basically reconstructive surgery, not done by orthopedic surgeon. It is done by reconstructive team, which will have one aspect of ortho, जो bone में help करेगा, which even plastic surgeon can do. But it's a plastic, ortho, and a neuro. It's a reconstructive branch in itself, and they do those transplants. And Amrita Kerala is the only center in India which is at the moment doing it.
But they are now training their team here in Faridabad.
It's too long, I mean, because the persons who are doing it, they are still stationed in Kerala.
Yes, sir. Yes. Thank you.
Dr. Shane Gupta, he has a question.
Not a question, really, just a comment. I know Dr. Ramneek because personally, otherwise also he has operated on my mother-in-law. She is still doing well, thank you. All the cases that you show, these advanced cases, we as physicians, surgeons and in general practice, beyond the point we do let the patients be under orthopedic follow-up, and very sadly, most of the people who are not operating or not doing what you are doing, they tend to, I don't know if I should be using the word misguide them, doing all kinds of injections or physiotherapy and delaying the thing to an extent that nothing else is possible except doing more than what you should have done at a particular stage. So that's just a comment. I think you should have parallel CMEs with people, especially the older generation people who refuse to let go of patients just citing something or the other, especially physiotherapy and all kinds of things, and do not let the people get operated or get some kind of a good rational intervention at the right time.
Very right. Dr. Ashok Arya has been wanting to ask a question, very angry with me. Ask the question.
Not like that. Doctor, as you said, in case of urinary tract infection, you don't go for surgery. The patient who is diabetic on SG2, GT inhibitors, they usually have laryngitis, urethritis. Do you take up those cases only who are not on SGLT2 inhibitors? If they are on these medicines, then you have to stop those medicines to control the diabetes?
Yes, sir. All those who are taking those medicines which cause glycosurias. So
how much time do you give them to?
So normally see where I work, it's a team effort. So I take the help of the endocrinologist. And so normally what I try to and what we are doing, we are practicing it is that all those patients who are on these glycosuric drugs which give you glucose out, they have to stop it. We try to either counsel them to go on your insulins, or then they look for other aspects. I'm not an expert on that, but I can tell you, we stop, we treat, and then we operate.
How long do you take after surgery to start their SGLT inhibitors?
I don't know, sir. That is
They usually cause inflammation actually. They usually cause.
सर नॉर्मली हम लोग तो छोड़ देते हैं
डॉक्टर रमनीक पंगे नहीं देते। मैंने देखा सर अपने अंकल के केस में देखा है, No. He operated on my Fufa ji and he operated on my another uncle, Mr. S K Poddar, who went to US. And he was that on that. He told me, Dr. Chauhan, yeah, at least control his diabetes.
We have to breastfeed these kind of knowledge.
He asked me to, because he was not controlling it, he was not taking my medications, he was not taking any medication from Max, and he told me, yeah, diabetes तो control कर दो ना, अगर वो control नहीं करोगे तो बाकी तो सारी की सारी प्रॉब्लम खत्म हो जाएगी। मैं जितना मर्जी बढ़िया जॉइंट लगा दूँ,
And he's doing well now, sir. He's doing well now in US. Okay, but he was not doing well. Every day he used to call me, yaar mera, yaar, ye ho gaya, wo ho gaya. He was blaming everything on you.
But if the patient is efficient under their care, they have to take care of the damn.
Sir, Dr. Arya, that is what I'm saying. That is what I'm saying. They are not endocrinologists. They will only refer it to somebody. The problem was that my Dhufaji, when he was referring, एक मिनट सुनो यार, when he was referring him to the
Why do I need 90% of these patients are already taking calcium? You want me to stop calcium before
I don't want you to stop calcium. I like you to probably give them either teriparatide or denosumab to improve their outcomes.
So all those patients who will feel will have osteoporosis, when we are operating, we get to know the quality of bone without damage. We give them at the time of discharge, we give them denosumab, and we tell them to come back to us in the next follow-up with a parathyroid hormone and a calcium test. And if they don't have hyperparathyroid, if they don't have hypercalcemias, and they don't have a past history of cancers, we start them on teriparatide. We don't need a bone DEXA scan for them.
Okay, so Dr. Ramneek says you don't need a DEXA scan to prove that the patient has osteoporosis.
He is operating. I have already operated. He can see the bone.
So, before you operate, would you recommend teriparatide or denosumab in such patients who have severe osteoporosis? Why I am saying that is, recently JAMA Rheumatology talked about a phase 2 trial which said, please maintain silence at the back. So it said that probably if you give denosumab, the chances of osteolysis after a total hip arthroplasty is much reduced as much as 83%. So I would probably, I don't know, I'm not an orthopedician, you would probably recommend denosumab in such like patients who have, increased osteolysis.
A frank osteoporosis which I can see, then they are always put on denosumab at the time of discharge. And no denosumab given before surgery will help. It doesn't happen with one shot. And the problem with denosumab, sir, is that we as clinicians, they are not seeing physician or orthopedic surgeon or anyone. We have started using denosumab left, right and center, but we don't know what is the problem with denosumab. And the problem with denosumab is that if you start it once, then you cannot stop for the lifetime. Because the moment you stop denosumab, you have a high chance of vertebral spinal fractures within the next 2 years. Absolutely true. So that is why denosumab has to be thought of before starting, and you have to then plan or chart it out for that patient in such a way that when, like we do as orthopedic surgeons in our practice, which probably is a level 6 evidence, is we start denosumab. For us, the important critical time is till my implant or everything settling down. So it's 4, that means 2 years, 4 shots. And during the subsequent times, if we know it is an established osteoporosis, we'll start teriparatide. But then it is the job of endocrinologist to handle it, and all patients who we suspect, हमें clinicians को छोड़ने की आदत डालनी पड़ेगी. हम पकड़ के जो बैठ जाते हैं पेशेंट को, वो गलत है. मेरा काम उतना था जो किया. अब जिसका काम है वो करे. इसलिए we refer them to endocrinologists or physicians who are tracking them.
So why I said that was probably, these are now the DMODs. So disease modifying osteoarthritic drugs. So probably the chondroprotection cartilage and the regenerative effects have been seen with such like drugs. That's why I said that. Thank you, sir.
Dr. M.L. Kalra sir will wind up the question answer session. I'm sure he will be very kind to Dr. Ramneek Mahajan. He has to attend a family function.
Sir.
पहले तो मैं ये कहना चाहता हूँ कि आपसे मिलके बहुत समय के बाद मिले हैं। मेरा एक कमेंट ये है कि आपकी सीएमई की हाफ लाइफ 3 महीने है। 3 महीने के बाद अगर आपने दोबारा हाफ लाइफ नहीं दी, दोबारा सीएमई नहीं करी, तो आज वाली पे कोई मीनिंग नहीं है। ये जो अभी तक जो बोल रहे थे ना, वो सारी आई तो है।
Dr. Kalar sir, Dr. Ramneek never says no to the CM.
सर, तो मैं भी
लेकिन सर एक बात है, मैं and I would be very dead honest and very frank with the forum. Dr. Ramneek should get the support from the forum that he deserves.
The same I want to say.
I take everything to him, whatever it is. चाहे elbow fracture हो, चाहे CGHS patient हो, कुछ भी हो, I take it to him. I tell him आपको करना है, and he's always willing. But बहुत सारे लोगों की प्रायोरिटीज जो है डिफरेंट है। आप अपनी प्रायोरिटीज जो है सेंटर कर दीजिए इधर, एंड आई अश्योर यू कि 4 CME कहीं नहीं गई।
थैंक यू सो मच सर। मेरा कोई सवाल नहीं है, मेरा जवाब ही था।
Since we have Dr. Himanshu Kataria here, I would request him to summarize this CME for us. Say your message for our members.
So I think it's the very fact that we've got such an interactive audience and we've asked so many questions. Sir ने तो जामा तक खोल दी। I'm actually really impressed. On a very serious note, you are fantastic at asking those questions. So I think the basic idea which Dr. Mahajan has tried to convey and which I would like to convey is that let's pick up the cases on time. Let's not simply wait for a grade 4 or a person who is unable to walk and then refer him to an orthopedic surgeon. That is one. And let's not have age as a criteria at all. I think that's the most important thing, because when he talked of 14 years, 19 years, I just wanted to add the point that agar wo joint 15 saal, 20 saal chala, you have given him wonderful productive years. Very good. That's the time you want to enjoy everything in life. So I think we don't wait कि ये चलते रहने दो 70 तक 60 तक. Forget the age. I think let's look at the quality of life. That's the only thing that we want.
Well, so my last comment.